computer. There we go. So I hope you can all see me. There. You can all see the screen and you can all see me. So tonight we're going to talk about sleep during the menopause transition and beyond. It might not be exactly what you expected because as I got into it, I thought, I really need to focus on certain things. And I will ask people to stop their videos and stop their microphones during this presentation. Okay. Don't worry, we will have time for questions at the end. So I'd like to start with a land acknowledgement. I live and work in Sudbury, Ontario. It's the land of the Atitmaching, Anishinaabeg, and Wahnapitae First Nations, and I do extend my deepest respect to Indigenous peoples. I'd also like to give disclosures. I'm not supported in any way for this, but I do have some affiliations that you can see there for other presentations. I also have developed a course, Menopause Review for Primary Care and Working with Menopause. Okay, to start. Well, a little bit about my story. I told you that I work at Laurentian University in Sudbury full-time, and many of you may not know that it went through bankruptcy a few years ago. So although I've always had casual work as a nurse practitioner, I wasn't sure whether I was actually going to have a job at Laurentian University. So this was a few years ago, and I thought I would like to do something different and interesting and fun should I not have that full-time job anymore. And one thing I thought of was, menopause care. Wow, it's everywhere. I'm a woman of a certain age, so it impacts me. So I thought, well, I'm going to start a menopause clinic. And I thought, this is great. And I thought, I'll just brush up on some of the newer guidelines and stuff. And oh my goodness, there was so much information that I had no idea about. It was alarming and it was upsetting because I follow best practice guidelines for other stuff, diabetes care and hypertension. And for some reason, this was missed. And I think it's been a testament to the WHI study that came out and really shut the door on menopause care for 2 decades. It's been horrific. Anyway, so I went ahead and got certified through the Menopause the Menopause Society, and I opened the clinic. And what I discovered was that women are suffering. They are suffering big time. And it's not just hot flashes. Hot flashes are the tip of the iceberg. They're the things that sort of we talk about that are tested and everything, but menopause symptoms, perimenopause symptoms impact every part of our lives and women's lives. So let's get into this a little bit more. But before we do, I just want to say my goal is really to give you some strategies on how to approach one aspect of problems with menopause and perimenopause, and that's sleep disturbance, particularly for women in the menopause transition and perimenopause. We don't teach or learn this well in NP schools. We still don't. I know they've upgraded stuff at Athabasca. It's still not really great, and neither is it anywhere right now. And there are also a huge lack of sleep specialists. So hopefully tonight you'll get some information that will help you with some of the things that you can do in your practices. All right. So why is it important? Well, there are many, many people who suffer from menopause. It's a pandemic, if you will. Let's just say the mean age or the average age of a woman having their final menstrual period is age 52. And that's 95% of women will have their final menstrual period between 45 and 55 years. And I should add before I go too far that tonight I'll use the term woman, but there are many people who have menopausal symptoms. So keep that in mind. In Canada, 52% of women, the female population are age 40 and over, that many women will spend 40% of their lives post-menopause. So this is millions of women, millions. And we're just now beginning to understand a little bit more about how this huge change in our lives impacts us, not only during the time, but then moving forward. So I think it also is important to understand that loss of productivity globally from menopausal symptoms can be as high as 150 billion US dollars a year. And that includes sleep disturbance because if you don't sleep well, you're not functioning well. And people just sometimes have a difficult time going to work. In Canada, the estimated days of lost work due to menopausal symptoms is about 540,000 a year. So, of course, menopausal symptoms interfere with women's well-being, but often they attribute those changes. They think, oh, well, it's only hot flashes. And they don't understand necessarily that sleep disturbance and a whole bunch of other things are related to perimenopause or menopause. So they just attribute it to that and they don't get treatment. And unfortunately, we are also to blame for this because we kind of don't put it all together either in clinic. We don't also look at the health risks related to some of the symptoms of menopause. And again, 80% of women go untreated for any symptoms of menopause. It's important as well because your health at midlife is the best predictor for your health for the rest of your life. And the symptoms of menopause are not benign. So we'll talk about sleep tonight, but I just want to add here's one example. Hot flashes, the frequency and intensity of hot flashes are significantly associated with cardiac events in later life, independent of any other risk factors. It increases your cardiac events. So if you have a lot of hot flashes, or if a woman has a lot of hot flashes and they're really intense, her risk of a cardiac event goes up 50 to 80%. This is not small. And is it anywhere in our information, in our in our cardiac guidelines? No. Sleep is also a huge concern that the majority of the patients that I have are impacted by. And I'll demonstrate that it goes well beyond perimenopause into the postmenopausal time. So it has huge implications for health. So addressing things in this time frame for a woman is huge in having good quality of life moving forward. All right, so tonight we're going to look at how sleep is impacted by menopause. Now, we're going to review major sleep disorders during the menopause transition and beyond. Yeah, I'm not going to get into all of them, but I think I'm going to give you a good basis and sound foundation to moving forward with some practical strategies to adopt pro-sleep strategies for women. All right, let's talk about what menopause is. From a medical point of view, menopause is one day of a woman's life. It is the day 12 months after their final menstrual period. And perimenopause and menopause transition are characterized and defined by menstrual cycles. But that's not how it works in the real world, is it? I mean, from a social perspective, people talk about I'm in menopause or I got the perimenopause. They're not talking about cycles necessarily. They're talking about symptoms. So we have to be really clear that we don't just bog things down with the rhetoric, and we don't focus so much on cycles that we forget to treat their symptoms. I often tell people when I do presentations, treat symptoms, not cycles. You don't have to wait till a woman is completely finished and has her final menstrual period before you address the real problems of menopause and perimenopause that can arise, because there are a lot of them, and it really impacts women's lives. So let's go on. Don't be alarmed. There are a few slides here that I just want to give us a bit of a background again. So remember the menstrual cycle. FSH rises at the beginning, and that creates the development, maturation of a follicle or an egg. It's the lining of the egg or the egg shell, if you wish, that produces beta estradiol, which is the most potent estrogen in your body, the most plentiful and potent in a woman's body. And that is important because that is where the estrogen in your body comes from. And menopause is characterized by a lack of that. Once you've gone through menopause, you don't have a release of eggs anymore, and you don't have any estradiol. And that is what menopause is. It's an estrogen deficiency. And it's not unnatural, but it does cause some trouble. So what it does is the egg has releasing the estradiol. It causes LH to peak, and then which causes progesterone to be produced, which then causes the lining of the uterus to be thickened. And if the egg isn't fertilized, then there's a period. Well, we're born with hundreds of thousands of follicles. As time goes by, decades go by, we lose more and more. By the time you get to your final menstrual period, you probably have about 1,000 follicles left. So way lower, a percentage of what you started with. What it means is that as we get closer, I'm going to ask that people stop putting their videos on if you don't mind. As we get closer to your final menstrual period, FSH has to rise higher and higher and higher in order to be able to get one follicle to mature. So sometimes, every now and then, it can't rise high enough to let a follicle go out. So you don't have estrogen in that cycle. You don't have that burst of estradiol. And that can create a bunch of trouble. And there are other times when it rises really high and it's like, whoa, and then two follicles are develop, and you get an overabundance of estrogen, and then you get the problems with too much estrogen. When finally, over a period of years, several years, you get to the point where FSH just cannot rise high enough to to mature a follicle, and you go through menopause. So, okay, no, I'm sorry, I'm not answering questions right now. I mentioned that earlier. We'll get to that at the end. All right, so you can kind of tell that the changes and fluctuations in the hormones are kind of problematic for women. And keep in mind that every woman responds differently to the changing hormones. And also, I should add that we have estrogen receptors on every cell of our body. So it's no wonder that there are multitudes of symptoms that can occur during this perimenopause and menopausal time. This I'm just putting up to demonstrate to you a little bit more information. The SWANS study, or the STRAW study, it was a study of tens of thousands of women to map out the reproductive ages of women who go through natural menopause. So this isn't menopause induced by surgery or radiation or chemotherapy or anything like that. But what it does show is a few things. So for example, menarche, they first get their period, you're given a score of -5. And then as you go along your reproductive years and the menopause transition and postmenopause, you get different scores. But you can see a few things. First of all, that all of these stages, even though they give them a couple of years here and there, they mark them, are variable. That's just an estimate. That's an average. Women have quite varying ranges of when they're going to have these, go through these different stages. The other thing is the menstrual cycles change dramatically as you get closer to the final menstrual period. And at the same time, you'll see FSH lower down. It's variable. This actually points out that it's doing blood work for hormones for somebody who is going into the menopause transition is not helpful in identifying which stage of the menopause journey they're on. It's also not helpful in identifying what symptoms they have or how to address them. So it's helpful, but it is helpful for a woman if they want to know what stage they're in, if they're going through natural menopause, to follow their cycles. And you can get a rough estimate of where you're at with that. So it does give some information, but it's very cycle oriented and it's not symptom oriented. And remember what I said, women can have varying responses to the changes of estrogen and progesterone, regardless of their cycles. So while it's helpful to have this information, it does show that you have to pay attention to the woman's symptoms. All right, and this is one more sort of technical slide, and then we're going to get into sleep. See how estradiol rises dramatically in puberty, fluctuates dramatically, throughout the reproductive years, and then drops pretty well like a stone for a few years. Compare that to testosterone in males that has a slow and steady decrease. So it's no wonder we have women experiencing quite dramatic symptoms. So how do estrogen and progesterone impact sleep? Well, sleep architecture. So that is, we have different stages of sleep. We have light sleep and deep sleep and restorative sleep and REM sleep, all those different things. They are impacted by hormones, age, and stage of the menstrual cycle. Estrogen actually promotes good sleep. It promotes REM sleep and the total sleep time. It decreases sleep latency, and that's the amount of time it takes when you decide you're going to fall asleep till you actually do. You're in bed, cover up. and nighttime awakenings. And progesterone, the same thing. It increases the non-REM sleep, so the restorative sleep. It has a sedative effect. So women who are at the end of their cycle, close to their periods, will say, "Oh my God, I'm so tired." Well, some of that might be a little surge of the progesterone there. So it can be used to help with sleep, and we'll talk about that in a bit. Again, it decreases sleep latency and night wakenings, but it can become habituated. All right, let's talk a little bit more. Okay, what's going on here now? There we go. Come on, come on. There we go. Studies have shown that women have increasing difficulty falling asleep, waking up in the night, and waking up too early. It gets progressively worse from the pre-menopause to the perimenopause, in different stages to the post-menopause. Sleep for women gets worse and worse and worse as we age. And that's really important to know because women may not really attribute that to changes in hormones when in fact it can be. I was at a conference, the Canadian Menopause Society conference last November, and this guy down at the bottom, Dr. Kular, so I adapted the slide from his presentation. He said in his practice, he thinks that the first sign of perimenopause is sleep disturbance. So that tells you how relevant and important it is in the mind of a sleep specialist. So we do know, again, women in the peri to post-menopause sleep less, report more insomnia, and are more likely to use sleeping aids. But not only hormones cause issues with sleep in women of this age. There are working mothers. This is reported issues. So working mothers, 72% of them and 68% said that they suffered from insomnia, single working women, sorry. Many women develop dysfunctional sleep behaviors. There's general aging, which causes you have to do things like get up in the night to pee. Noise is a factor. Childcare is a factor. Sharing your bed sharing with pets and children and a partner who snores and tosses and turns. And 47% of women say they have no help with caring for children at night. So those are issues that we all can talk about, but it's not the whole issue. It's not the whole problem. We know that fluctuating hormones can cause hot flashes and things like night sweats. So the interesting thing, though, is, and that could wake women up, but women do wake up because of night sweats, but some studies show that 20% of the time women wake up prior to the night sweat. So it's almost like what came first, the chicken or the egg? Was that rush of cortisol when they woke up the result? Did it result in a hot flash, or did they have a hot flash and woke up? I don't know. There's an increased risk of sleep-related disorders like obstructive sleep apnea and restless leg syndrome and insomnia. There is pain or medical conditions. So the difficulty, though, is women experience more joint pain when they go through menopause. And women experience an increased risk of things like cardiac issues and diabetes, which can impact sleep. So, it becomes very difficult to separate everything out. Again, mood disorders and ADHD. As a society, we're okay. We all understand a medical system that women experience mood changes with fluctuating hormones, say for PMS or the severe premenstrual disorder. We also are happy to understand and to help women who've gone through childbirth and have that huge reduction in estrogen that supports child pregnancy. We understand, they are vulnerable to mood disorders or changes because of that changing in hormones. Then we get to menopause and the menopause transition, and women's hormones are fluctuating all over the place, and they become depressed and anxious. And we say, well, you have a generalized depression or anxiety disorder. You have something else. We need to understand that, of course, there are circumstances that are not hormonally related, but there are often times when there are changes during this time that women are experiencing these changes because of changes in hormones. So keep that in mind too. I also wanted to add another thing. They found, science has found where hot flashes originate in the brain, in the hypothalamus. They actually discovered it in 1993, but they developed a drug for it based on that in 2023. So it only took 30 years, but anyway. So there are neurons in the hypothalamus that when estrogen drops, these neurons release more of a chemical that then causes a hot flash. Well, very interestingly, there are receptors for both mood and sleep very close to these receptors. Remember what I told you, that there are estrogen receptors throughout the body. So it's very likely that fluctuating estrogen does impact mood and sleep as well. Okay, so there are different types of disorders related to sleep, and we'll talk about these related to menopause. I'm going to focus in on insomnia and obstructive sleep apnea. Not that the other ones aren't important, but they're a little, I mean, certainly restless leg syndrome is fairly common, but I don't deal with it as often, and it's not as specifically related to menopausal symptoms. And the other ones, circadian rhythm, sleep disorder, primary disorder of sleepiness, parasomnias, things like narcolepsy, those are pretty specialized, and I would definitely consult with those. But let's look at insomnia. So there is a clinical definition for insomnia in the DSM-5. It is greater than 3 months for at least 3 times a week, having difficulty falling asleep or maintaining sleep or waking up early and having significant distress or impairment in functioning. And if the sleep problem can't be accounted by any other disorder, sleep disorder, or a medical problem or substance use. All right. The problem with this, and it's great to have this because then you're triggered like, okay, is this really insomnia? But the problem is that are you not going to treat? Are you going to say, oh, well, I think that this person also has depression, so I'm not going to treat the insomnia? Well, no, don't get into that mindset. If you can't specifically diagnose it as insomnia, does not mean that they don't have a sleep problem. They need help because what it can do is really impact their functioning, the women's functioning on a day-to-day life. So think about the symptoms that they have, the way their sleep works, and how it's impacting their functioning as the measure for whether or not you're going to go through with it and treat them. Oops, sorry. No, I'm going backwards. Go backwards. Okay. So again, insomnia can be difficult to separate from other medical disorders and say this is only insomnia. And you must address the comorbidities. So if they have diabetes, you're not going to let that go and just look at the insomnia. Or if they have depression, or if they have an anxiety disorder, of course you're going to look at those things. But it's important to also treat the insomnia. So there may be interactions, they may be bidirectional, insomnia is a risk factor for depression, cardiac disease is a risk factor for insomnia, like it can get crazy. But if the insomnia, again, is impacting their function, it warrants separate attention. So what do you do? Well, this is sort of a little blurb that will show you the direction we're going to go. For behavioral therapy and cognitive therapy, there's something called CBTI, and that's cognitive behavioral therapy for insomnia. And as the name implies, it addresses behavioral and cognitive issues related to sleep, but it's very different than CBT for something like depression, etc. It's very structured. I'm going to go through a few of the points for it. So it includes, first and foremost, sleep hygiene. So most people know about this as a strategy, and it's you work on your sleeping timing and sleep environment, and includes things like don't drink alcohol at night, avoid caffeine during the day, keep your bedroom cool, only use the bedroom for sleep and sex. It's not effective for insomnia as if it's used alone. You must have other modalities to assist with it, particularly for chronic insomnia. So one of the most helpful, but one of the most difficult things for some people to do is sleep restriction. So you start with a detailed sleep diary. And the one thing you do is to calculate the amount of time that the person stayed in bed versus the amount of time they've slept every night for the week. And you come up with the average amount of time they've slept. Usually, for chronic insomniacs, the difference is huge. I had one patient who would go into bed about 8 o'clock, go through her phone for a few hours, and then try to sleep, finally fall asleep between 12:30 and 1, maybe, and wake up in the morning at 6 and have to get out of bed. Well, you want to retrain their brain. Their brain has learned that sleep is for scrolling on their phone and sleep is for doing everything but sleep. Or sorry, bed is what I meant to say, is for everything but sleep. They need to retrain their brain and they need to be in bed when they're sleepy. So sleep restriction is, in this case, I would say she would go to bed at 11:30. She would get up at every day at 6 in the morning. Is it interrupting the amount of sleep she had? No, because she wasn't getting more than 6 hours anyway. So that's pretty good. They do this, and then as time goes by, you can gradually increase the time in bed. But again, you have to retrain your brain. Next is stimulus control. And it's important to distinguish between fatigue and sleepiness. So fatigue is a state of low energy, physical or mental. Sleepiness is a state of having to struggle to stay awake. So dozing off while you're watching TV, or if you're a passenger in a car and you're kind of falling asleep, hopefully not the driver of a car. So people, that's sleepiness. And people with insomnia often feel tired, but wired up. So you want to create an environment where you have very little stimulus that's going to keep you going. Things like light. Light is a big problem because we have receptors in the back of our eyes that when we wake in the morning and open our eyes and light hits them, it wakes us up. So you have to include things like keep the lights dim. In fact, some of the stuff says to wear a mask at night. Some things are keeping a white noise in the background so that you don't get bursts of noise that then can stimulate you. So then it's a little bit like the sleep hygiene as well. One thing to do for all of this, okay, hang on. Oh, cognitive therapy. Cognitive therapy. I'll tell you that in a minute. Maladaptive beliefs regarding daytime and health consequences of sleeping. I've been reading a book that's fascinating about sleep, like blowing my mind. And part of it is that parts of our brain kind of stay awake a little bit and parts of our brain sleep when we're sleeping. So obviously not our whole brain sleeps. We're not all, completely out of it because we move, because we dream and stuff like that. But interestingly, the prefrontal cortex, which is responsible for rational decision making and calming us down and getting that kind of sleeps really well. Unfortunately, the amygdala in our brain, which is primitive, which is fight or flight, which is catastrophizing everything. Oh my God, it's wide awake in the night. So I don't know if you've ever experienced it where you're like awake in the night and everything's really bad. And it's like, oh my goodness. And you wait, and then you wait in the morning, you're waking up like, why? Why did I think that way? Well, your amygdala was probably going crazy. So you have to get people to retrain their thinking in the night as well. I mean, how many of you have had trouble sleeping and looked at the clock every hour on the hour and thought, oh, okay, if I get to sleep now, I'll have 3 hours of sleep. Oh my God, I'm only going to have 2 hours of sleep. Those are the kinds of thoughts that aren't going to be helpful, that are going to keep you awake. They're going to upset you. It's not good. So you have to work on those as well. One thing about this CBTI is that you don't stay in bed if you cannot get back to sleep. And this is really hard to get people to understand as well. They toss, they turn, they toss, they turn. If you're awake for more than 20 minutes, you get out of bed, but you don't overstimulate yourself. You don't put it on your phone because that light will hit the back of your eyes and away you go. You can have a dim light. You can read something. You can be calm and you go back to bed when you are sleepy. If you remember about the sleepiness rather than just tired. But it also, we're going to give you tools as well to help you. And one of them, the tools are relaxation things like mindfulness, like deep breathing exercises, because all of that calms down that cortisol rush that you had, the arousal that you've had that's got you wide awake. Okay. So CBTI, cognitive behavioral therapy for insomnia, there was a study where women were randomized to either education or CBTI. And the CBTI showed significant improvement over education alone. Other studies have also shown that people with comorbid chronic conditions also had improvement with sleep with CBTI. And it's hard sometimes to find somebody who can coach you through it, but there are apps now. Some are not free, sorry. But the trouble is with CBTI, it's work for patients. And sometimes they just don't want to do it. they don't have the time, the energy, they're not interested. So they might be willing to put some things in place, but it might be too difficult to do all of it. So look at other treatments. Well, if it's a menopausal, perimenopausal woman, why not consider implementing menopause hormone therapy if they have no contraindications? It's a way to address perhaps that symptom as well, the sleep problem, as well as potentially other problems with menopause. So estrogen can reduce night sweats that might be waking them up, and it'll improve sleep overall. Micronized progesterone. So there's progesterone that you take orally, and it can promote sleepiness. As it metabolizes, it has that same the sleepy effect that we talked about. It does improve sleep, and you would take it at night. The difficulty is that there aren't a lot of studies. There aren't any studies that were done, randomized trials in particular, that were done specifically to look at menopause hormone therapy and sleep. They are predominantly observational studies, and these are secondary findings from the main study. So there needs to be a lot of work before we can say, yes, this is a great option, but it's worth a try for many women. So sometimes you will give somebody a sleeping pill. Now, a lot of people, if you were like me, like, oh, I don't want to give sleeping pills, they'll get addicted and they'll be, but if it means that they function during the day, then it's really something to look into. And I'm going to talk about a few of them anyway. The medications differ by their mechanism. So many of the ones, the benzodiazepines and the Z drugs, are on benzodiazepine receptors. And this is a little bit misleading, this chart, because things like zopiclone, etc., they do work on benzodiazepine receptors. They just don't have the anti-anxiety component. They only have the sedative hypnotic component. But because they're on the benzodiazepine receptors, they have the same potential risk for things like building tolerance and addiction, which is very concerning. There are other things that are used, like the low dose doxepin, which is a tricyclic antidepressant, and it works by slowing activity in the brain. But this last one down here, the dual orexin receptor antagonist, I mean, I'm so excited about these, and I'll tell you why. All other products, even the off-label products that we will talk about for sleep, work on increasing sleepiness, the receptors to increase sleepiness. Dual orexin receptor antagonists work on decreasing wakefulness. And I know it's got to wrap your head around that a little bit, but they're two different receptors. And if you think about it, how many people do you know and have you experienced, and certainly a woman going through perimenopause and so stressed out, when we talk about this issue about fatigue and sleepiness, they are often exhausted. The problem is they can't get their minds to stop. So I have found that these lemborexant, Dayvigo, for example, has been incredibly helpful. It's also important that initially they said, no, it had to be used continuously, but now they're seeing that lemborexant in particular can be helpful for people on a PRN basis, for people who work shift work or people who are traveling, but it also doesn't have the same buildup of tolerance and addiction that some of the other Z drugs may have. So it's become a really helpful thing. And honestly, the patients that I've prescribed it to have said, wow, I felt something like that. Boom. And what they find is they still sort of wake up in the night, but they don't have the same, it can take the edge off of that, cortisol rush that keeps them awake. Okay, so there are off-label use of medications for insomnia. So clonazepam, lorazepam, I personally stay away from those. I see no reason to have them. There are other drugs that are as helpful, and those have too many potential risks. There are other antidepressants that are used. Mirtazapine is I see commonly in trazodone. Mirtazapine is an atypical tetracycline antidepressant. The exact mechanism for sleep isn't known, but it does concentrate neurotransmitters in the brain, noradrenaline and serotonin. I don't particularly love implementing antipsychotics as well, for a lot of reasons, especially if it's an older person, because there are potential side effects that are probably, risk benefit ratio. There are other products that you can use more safely. So if you want to look into that, I encourage you to look at it a bit more. Gabapentin, wow. It's used for everything. It was as it says here, an anticonvulsant in decades ago. Since then, it's been used off-label for neuropathic pain for, say, diabetic neuropathy, that sort of thing. It's also helpful for hot flashes, and it's also helpful for sleep. I would tend to go towards that rather than the pregabalin because pregabalin has been taken off of the recommended list for hot flashes, for example, because the evidence doesn't support that it's as helpful. You have a lot more leeway or range of dosages with the gabapentin. Anyway, if you're going to go that route, kind of steer towards the gabapentin. The devil you know, let's say. There are also SSRIs, SNRIs. They have modest effects, but again, limited data and short-term studies. Melatonin, there's actual evidence that it does help, but it actually helps more in circadian rhythm issues, like people who can't get their days and nights organized up well. It doesn't help as much with things like insomnia. Magnesium, again, if you watch Dr. Mary Claire Haver, she is a OBGYN in the US who has she's got books and she's got a social media profile, really, really wonderful support for women for menopausal issues. And she says, and she has said, and it's true, there are observational studies that show that magnesium helps. They're not, again, the randomized controlled trials, and there is some variation in the data, but women could supplement with magnesium anyway, may want to take it at night to see if it helps their sleep. Okay, now, again, I promised you we would talk a little bit about obstructive sleep apnea. And the reason being that it's hugely under-recognized, and it's 20% of women have, postmenopausal women have it, and it's hugely undertreated. But it also presents as insomnia in many cases because women keep waking up. The really bad part, though, is it increases risk of stroke by 60%, risk of coronary heart disease by 30%, and risk of heart failure by 140%. Okay, let's talk about this a little bit more. It's not just that you get fat and therefore you snore and therefore you have sleep apnea. There are changes in our pharynx related to the changes in estrogen and progesterone. Again, estrogen is on every single receptor of cell of your body. Your soft palate elongates, your fat pads increase, your bony airways change, and your response, the muscular response to airway pressure, diminishes. So women end up with sleep apnea and may not know it for a lot of reasons. Differences between men and women. Well, women are significantly more likely to present with insomnia. They're more likely to present with mood changes and irritability, GI reflux, nocturia, and enuresis. They are less likely to have witnessed apneas, less likely to have nocturnal choking, and less likely to report non-restorative sleep. So they won't have the same signs as men. It's much like heart attacks. So we're not going to be tested and treated for it. It's important to test properly, to ensure that people are there's my menopause brain going to use the correct tool to assess a patient. And the Berlin questionnaire is one that can help with women who present with these symptoms. So you look for suspicion of sleep apnea. You look for abnormal behaviors or movements during sleep, unexplained daytime sleepiness, or repetitive brief awakenings. And I'm going to tell you a little story. So, I don't know, about 7 or 8 years ago, I was working at a clinic and we had this competition where half of the people we all wore the Garmin. It was like a pre-iPhone iWatch thing. Anyway, we all wore the Garmin wristbands and monitored the steps we took because there was a competition for each team to take the most steps. But the thing was, when you wore it at night, it monitored your sleep. And sleep was shown as dark purple for really deep sleep or light purple for light sleep. And then awaking was pink. Well, my colleague showed me her graph the morning before or the morning after, and it was like dark and purple for the whole night. I showed her mine. I had 19 awakenings that night. So yeah, brief wakenings are one thing. And by the way, I ended up for a variety of reasons going for a sleep test, and I have sleep apnea, and I wear a CPAP now. Okay, I will show you a few things at the end. So menopause hormone therapy, that's what MHT is, significantly improves apneic episodes, but I wouldn't use that as the sole treatment. I would definitely, people need to have the CPAP or the mouth guard or whatever it is that will reduce their apneic episodes because of the huge risks for cardiac problems. It also, I should add, it also, lack of sleep also promotes weight gain. It's like and it increases your risk for hypertension. I mean, treating sleep is massive. All right, so I'm going to talk to you a little bit about how I approach somebody for sleeping. I'm going to stop sharing this for a second, and then I'm going to share something different. First of all, I'm going to show you just briefly, the Berlin questionnaire. And you'll be able to find these things online without any trouble. They are, all the things I'm showing you, they are readily available. So there's the Berlin questionnaire, and you can go through that at your leisure. I'm going to also show you, okay, and it's disappeared. Oh yeah, I know where it is. Okay, what I do when I have somebody come in, because again, I'm not a sleep expert. I'm not like a physician or certified in sleep, but I see people all the time with sleep problems. I want to be able to help them. I want to make sure I'm going in the right direction. So I use a tool like this. I hope you can see it. What it does is it gets the patient to estimate, to respond to a variety of questions. In this one, number one, it takes me 30 minutes or more to fall asleep. And they mark never, seldom, one times a year, sometimes 1 to 3 times a month, often 1 to 3 times a week, or frequent more than 3 times a week. And you go through a variety of questions. At the end, there is a scale. You add never gets 0, seldom gets 0, and etc. Then you see the questions. For insomnia, it's questions 1, 2, 3, and 4. You add up the score that they get. Anything over 5 is pointing you in the direction of insomnia. So I should add, it doesn't diagnose it, but it pushes you in a direction, and it gives me a starting point with patients. So for example, if they were high on the restless leg syndrome or narcolepsy, I would think about referring them to someone who has more expertise with that. But because if they are high on the insomnia, we can work with that. I've got some tools in my bag to help with that. With obstructive sleep apnea, again, yes, tools to help with that. Okay, so now we've decided that the patient maybe is suffering a little bit from insomnia. So what do? You can get them, if it's mild, you can talk to them about some of the sleep strategies that they can do on their own. But if you want to implement CBTI, get them then to fill out a sleep diary. They find it tedious. It's amazing. People don't want to do this stuff, but it's like, this is a way to get subjective information about the amount of time they are in bed, the amount of time they sleep in bed, how many times they woke up. Oftentimes how they subjectively rate their sleep. And also, I ask in the comments for them to put things in like, did they take anything? Did they drink alcohol before they went to bed? Did they try any medications before they went to bed? So that gives us an idea about a starting point for how bad their sleep is. Now, again, there are lots of tools available online. There are some that they're tested and reliable instruments, etc. So, certainly Alberta has a lot of medical tools. I think I got this one from the Alberta. There's a lot of medical information, I think, from their physician groups, etc. Okay. The other thing, though, is it can help us when we're planning something like the CBTI, so that we can decide what is their being in bed to being asleep ratio, and identify the strategies then for moving forward. So I just want to make sure I'm not forgetting anything. There are scales to ask about their functioning level and how difficult an insomnia index, so how difficult the sleeping sleep problems have made their day-to-day life. And that can be helpful too if you're wanting to measure how well the treatment is that you're giving them. So the next thing I would do, you got all that in place. Oh, I'm going to go back to my thing here. Okay. So the next thing I would do is collaborate with the patient about treatment and set expectations. Part of the problem is that they're probably not going to go back to how they slept as a child, for example, or even as a young person. That some people do extremely well and get back to regular sleep and can fall back to sleep well. People who've had chronic insomnia, one of my patients had chronic insomnia for like 8 years when I saw her. It's like, wow, we really have to work really hard to reset your sleep architecture, to get your brain to understand that it needs to sleep when you're in bed. So setting expectations for that kind of patient, really increasing sleep by 1 hour to 2 hours a week is realistic. So your goal again is not increasing hours of sleep, it's increasing functioning. And working with them on that can be really helpful. Again, treat comorbid conditions, like, of course, and then treat menopause symptoms, because regardless of whether sleep is an issue, if they have a bunch of other things going on, joint pain, brain fog, the hot flashes, like those things are going to impact their sleep and quality of life regardless. Try CBTI if they're willing to do the work for it, and try pharmacology. Now, okay, what do you prescribe? Well, again, we don't have clinical practice guidelines for choosing the kinds of medication for sleep that you would want. So a lot of it comes to, what's your knowledge level? What's your experience with certain medications? How do you think how it will fit in the patient's life? Do they have a drug plan, for example? Because maybe Davigo, the one I talked about that I'm all excited about, maybe they don't have a drug plan and they can't afford it because it's not on their drug plan yet. So it's not wrong to try other products. Again, evaluate risks, benefits with the patient, and follow up. So again, I think just to summarize this whole sleep thing, especially for women in the perimenopause and menopausal ages, I think it's really important to recognize that sleep is a huge problem for a lot of women, and that it's really important to provide them with some treatment options, some support during that. And that's it. So there we go. There's one question already. So Sally says, what about bioidentical hormone therapy? Seems to work very well with insomnia, hot flashes, and the rest of the symptoms. All right. Bioidentical is not a medical term. What it means is that products that have estradiol, remember that's the estrogen that your body produces, and micronized progesterone, which is the bioidentical progesterone. There's sort of a misconception that is only available in the ground up stuff that the pharmacy grinds it up and puts it in cream and you put it on. No, there are pharmaceutical products that have both estrogen, a bioidentical estrogen and progesterone. I personally don't prescribe the compounded because I have a license in Alberta and Ontario. I work only virtually. I don't know the pharmacists. I don't know what their background is. I don't know what product my patient's going to end up with, but I do know the evidence and the research that's been done on the pharmaceutical products. I know the non-medicinal ingredients in them, and I can tell patients, these are the risk factors. This is the exact dose you'll be getting. So I think it's also dangerous to assume that it's separate. Bioidentical hormones are separate from other hormones. No, it's hormone therapy. And all hormone therapy have been shown to reduce risk hot flashes, to impacts the symptoms, and there are benefits and risks and differences to different products. So there's a whole, other, it's very political right now. Actually, it's political because I'm sort of on a soapbox, so I apologize for that. But I think that for 20 years, for 2 decades, women's health has been like in the back burner. So a lot of the providers who were providing menopause care didn't necessarily have the full range of pharmaceutical products available to them to give. So they promoted what they could, and a lot of that was compounded. So I don't bash that at all. Good for them. They were providing women with care. But I think the advantages of looking at the full spectrum is that you can give women a variety of choices. So there's my, and then my preceptor and I prescribed Dayvigo today. Good, great. Again, it's not to say that the other medications don't work, but this one I found in particular with women who are in the premenopause, perimenopause, they're going through that, they're exhausted, but they cannot turn off their minds. And this Dayvigo seems to help with that. So I'm kind of excited because it's nice to have tools to help with those things. Any other questions?
Hi there, Roberta. Thank you very much for all of your information. As a woman of a certain age, I would have to say I would have loved to have met you in the perimenopausal stages of my life. What you're talking about is fantastic, and I applaud you for that. I totally agree that as a upcoming prescriber, I think there's a lot we need to learn and to be able to offer women. So I will carry on with what you're doing and continue to try and learn. And thank you very much.
You're welcome. And again, I remember it was only 2 years ago I started this menopause clinic, and I was a little horrified and ashamed at how little I knew. I think nurse practitioners are a particular advantage with sleep issues because we're often salaried and not fee for service. We can often give a little bit of more time to patients with respect to the counseling and stuff that they might need to help them sleep, because ultimately setting up good sleep um, behaviors is is going to help them for the rest of their lives. Whereas a medication, yeah, it's a hugely important tool, but let's face it, it's better if they can do it on their own. Okay, at age, could you share a link to your course? Yes, I can do that. Um, at age 47 to 48, I began having panic attacks with burst of tachycardia. One doctor said, I went to said, hey, this might be perimenopause. Because how many women do you know that get to a certain age and end up with a Holter monitor for 48 hours and everything's normal? It's because one of the menopausal symptoms is like heart palpitations, definitely. And again, what are you going to do? You have to check them out. You can't just say, oh, well, it's just menopause. But if you've done the check and stuff, I've been on it, Davigo, for 6 months now, and amazing having tried other medications that simply did not work for me. Well, that's great to know. And I think it's, again, I have patients who don't have it on their drug plans, but were willing to try it and pay for it because of the kind of problems that they have. Um, and they were really thrilled with the results. So unfortunately, it's not going to be every patient, but it's kind of nice to get something that, is really helpful. So there's a course that I have. Um, primary care, and what is it? Menopause review for primary care. And again, you are getting tools in your program. And I shouldn't say that it's not up to date because I do know some people who've just recently updated the women's health course. So, I think you should definitely go back to that literature and before before you are interested in going outside of that. Yeah, I'm actually going to share the whole presentation if that works, Valerie, because um I've been recording it. I guess I can also share the presentation too. Doesn't really matter. Oh, yeah, go ahead. And I don't know your name. Beth, go ahead. Oh, I don't hear Beth. I don't know if she wanted to say anything. Anyway, can have these interventions work for patients with oophorectomy, complete hysterectomy? I would say yes. And in fact, women who have their ovaries removed have a sudden loss of estrogen. They experience intense problems. Oh, sorry, that's okay, Beth. They experience intense menopausal problems and they need support. They need a lot of support. They can have estrogen only because progesterone is given to women for hormone replacement therapy or menopause hormone therapy to ensure that the lining of the uterus doesn't build up too much. But the problem, but if they want it to help with the sleepiness, I give it to them regardless. What do you do to treat women in perimenopause with changing hormones every month that affect chronic conditions like diabetes? You don't give them hormones to treat diabetes, but stabilizing a woman's hormones can help offset the slowing metabolism that then increases insulin resistance and some other issues that can uh, impact their diabetes. So again, treat their symptoms, and for perimenopause and menopause, and at the same time monitor how they're doing with their chronic conditions. One thing that does change that I've noticed is that often women's thyroid medication, if they're hypothyroid, has to be adjusted when they start on estrogen in the perimenopause. So there you go. Birth control pills like progesterone, yep, if there are no contraindications, yep, birth control pills are perfectly fine. That progesterone is it's not used quite the same way as the progesterone you take at night. Like you take the pill at night to help you, and it does help with sleep. But some women, for example, have IUDs, and then you give them progesterone separately. If they're on birth control pills, I have given progesterone separately, keeping in mind that some conditions like PMDD, premenstrual dysphoric disorder, which I've seen a lot of actually, have also been, I've also treated with additional progesterone at night. So it seemed to have helped with their mood, stabilize a whole bunch of stuff, and help with their sleep as well. So some of these things aren't magic pills. I'm not going to say that, woo, you must do this, you must do that. And they have to meet the criteria, obviously, for any of these medications. But sometimes they can be really helpful tools in giving the women the energy and the time to kind of elevate them to the point where they're getting enough sleep and their symptoms have reduced so they can actually work on some of the other stuff that's really going to help, like exercise and stuff. Patients self-refer. They can log into my website and go through all my stuff. And if they want to join, if they want to have a consultation, there's a free 15-minute appointment to find out what I do. And then if they want to sign up afterwards, they can. Unfortunately, we don't have a mechanism for payment, so it is private pay. But I'll just give you that. And again, I see only patients in Alberta and Ontario, but there are a number of other providers available, and they work across different places across the country. And the one thing I've learned is there are more than enough menopause patients to go around. So I think I'm not going to run out of people, let's just say. Sadly, because I think we all should be able to do this care, and we all should be paying lots of attention to women in menopause. I'm very much on a soapbox. In particular, the sleep is a big one, and I'm getting into that more and more, but in particular, cardiac risk. It is alarming how our cardiac risk increases during the menopause time and how little attention everybody's paid to it. Cholesterol levels go up, hypertension goes up, risk for cardiac events go up. It's, 50 to 80% risk. With hot flashes. So not okay that it hasn't been addressed. It should have gone into the American Cardiac Guidelines in 2022 or something, and the Menopause Society put out a scientific statement indicating why it should have gone in and what was wrong with that. And Canada, we really need to get our acts together and really make this an important issue for women, because we all end up dying of heart attacks. Okay, maybe not. My family, they do. Okay, one more thing. Exercise. It's the least, like we always push it. Okay, yeah, you're supposed to exercise, Okay. In Canada, adult women, only 38% of them exercise. So less than half, almost only a third. And of women who exercise, people who exercise, only 63% of them do not exercise with enough intensity to get health benefits. So there's a huge, but it can make a huge difference in your cardiac health, in your symptoms, in your sleep. It needs to be promoted with every single person, and I do that. And it's a tough sell. It's like CBTI, but it's really important. Okay, it's 8 o'clock, my time. So it's been an hour, and I was going to let you go unless there's a burning question. But thank you everybody for joining, and I'll make sure that Lynn, I guess, has Dr. Miller has these things. All right, you're welcome. Great. Thanks for joining.
Thank you so much. Thanks for the link as well.
Oh, you're welcome.
Bye. Take care.
No
Thank
problem.
you. Have a good night.
Good night.
Thank you so much.